Hi, everyone. I'm Miguel Reguero, and on behalf of CME Outfitters, I'd like to welcome you and thank you for joining us for today's educational activity entitled COVID-19 and its impact on patient care and IBD, What Clinicians Need to Know. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. CME Outfitters greatly acknowledges the educational grants from Janssen Biotech and Takeda Pharmaceuticals in support of this activity. Today's CME and CE activity is eligible for ABIM mock points, so make sure you engage in today's event. Answer our polling questions, submit your questions, and provide feedback. Once you've completed today's program, be sure to provide your ABIM ID and birth date in the evaluation. CME Outfitters will submit your mock points. You can also claim this activity as CME for MIPS improvement activity, so please make sure to participate and provide examples of how you'll change your practice. And CME Outfitters will send you confirmation of your participation, which you can also submit to CMS. So as I mentioned a minute ago, I'm Miguel Reguero. I'm professor and chair of gastroenterology, hepatology, and nutrition, and the Pierre C. and Renee A. Bora Family Endowed Chair in gastroenterology and hepatology at Cleveland Clinic in Cleveland, Ohio. And first, let me introduce our faculty who really need no introduction. First, I want to welcome my colleague and good friend, Dr. David Rubin. Dr. Rubin is the Joseph B. Kirstner Professor of Medicine, Section Chief of Gastroenterology, Hepatology, and Nutrition, and the co-director of the Digestive Diseases Center at University of Chicago Medicine in Chicago, Illinois. Welcome, David.
Hi, Miguel. Thank you.
And also, I'd like to introduce my colleague, not too far away from me right now in Cleveland, Dr. Florian Reeder. Dr. Reeder is the co-director of the IBD section and director of IBD research and the director of the IBD Advanced Fellowship at the Department of Gastroenterology and the Department of Inflammation and Immunity at Cleveland Clinic in Cleveland, Ohio. Hey, Flo.
Thank you for having me, Miguel.
So let's go ahead and get started. Our first learning objective is to examine the latest evidence on current and emerging treatment and prevention strategies for COVID-19 and its associated symptoms in GI patients. Dave, why don't you walk us through? I've seen your slide deck. This is truly phenomenal. And I think everybody out there, you're really in for a great treat. But talk to us about COVID, what we know about COVID, and how it relates to IBD. Go ahead and take it away, Dave.
All right, thanks, Miguel, and thank you everybody for joining us for this very timely program, not just because all of 2020 has been consumed by our focus on the pandemic, but obviously in the last couple weeks, we've had some exciting news about vaccines. Let me remind you about the origins of all of this. First of all, there are hundreds of different coronaviruses, and most of them live in animal hosts. And some have been known to jump into humans. And the first severe acute respiratory syndrome was reported in 2002, 2003, and occurred in Asia. And then there was a Middle Eastern respiratory syndrome in 2012. These were both caused by coronaviruses. Now, the reason those epidemics didn't become pandemics was partially because they were contained early by people who took precautions and isolated it, but also because they actually were more lethal than what we've been dealing with over the last 9 or 10 months here in the rest of the world with the most recent novel coronavirus. COVID-19, which stands for the Coronavirus Disease 2019, was caused by another coronavirus, which was initially called the novel coronavirus 2019, and then earned its name, the severe acute respiratory syndrome coronavirus 2. And they renamed the one from 2002 SARS-CoV-1. So you may not have known all that history. The incubation is a median of between 4 and 5 days where you have the virus in you and before you develop symptoms. and the range is between 2 and 11 days. So that informs why we have people isolate or quarantine when they've had known exposure or when they even test positive but are asymptomatic. Of course, you know the usual symptoms of clinical presentation with respiratory tract infection. There may be just the new loss of taste or smell, or even just congestion. But of course, the more serious manifestations are when people develop respiratory symptoms that include a pneumonia or abnormal imaging. And it was early appreciated that GI symptoms may occur as well. And I'll go into that a little bit more. We also know that as this manifests, the more severe parts of COVID-19 include an overproduction of inflammatory proteins, and this can lead to a storm-like situation with a very highly coagulopathic situation, as well as, or prothrombotic situation, as well as multi-organ system failure and death. When you should suspect COVID-19 is described and updated by the CDC. And of course, that's your patients who have fevers, chills, cough, shortness of breath. It can also present as just this overwhelming fatigue or myalgias, headaches, as I've mentioned, the loss of taste or smell, a sore throat or nasal or sinus congestion, as well as the digestive symptoms of either nausea or vomiting or diarrhea. Also, patients may present with new abdominal pain. So when we're talking about our patient population as gastroenterologists who may have chronic intestinal problems, you can imagine the overlap there and how important and confusing this can be for us. In addition, we should suspect it when there's been a known exposure to an infected person, and that obviously has been happening more and more throughout the United States. Abnormal chest imaging without other explanations. And there are some laboratory abnormalities that can go along with this, including lymphopenia, elevated white blood cell counts go along with this as well as elevated inflammatory markers like CRP. And then obviously there are some emergency warning signs. Let me show you a cartoon that describes the different stages of the COVID illness. And this will also inform us when we think about why we know some about treatment in one phase, but it may not be as effective in another. As you can see from this diagram, going from left to right, stage 0 is when someone's not infected or may have had an exposure. But in stage 1, the early infection is when people feel like they have the flu. That's the usual symptoms and what most people have experienced and have recovered from. But I want to point out to you that as you move into stages 2 and 3, this is when you actually have the overproduction of inflammatory proteins and you actually enter a hyperinflamed state. And the hyperinflammatory state is not unlike what we see in Crohn's disease and ulcerative colitis, which has led to the understanding, as well as the research that backs it up, that some of our anti-inflammatory therapies in IBD have actually been used to treat COVID, but also may, when they're on board for other reasons, may actually be protective or result in better outcomes. It's important to keep this in mind because there's a difference between the early infectious stage and whether a therapy that our patients take for their disease might be putting them at risk for getting infected, and that same therapy that might reduce the likelihood of the hyperinflammatory phase where they can get very sick. Now, for the most part, the therapies used in IBD, as we're going to talk about, appear to be safe with the exception of steroids. Now let's look at the latest world numbers, and you may have already seen this in your morning watching of the news. You can look at this interactive map that the Johns Hopkins Health Security site has been running for us, and the entire world is just becoming one big red dot. But of course, the United States has the most and has the most condensed versions of this. There are now over 67 million confirmed cases around the world, and unfortunately more than 1.5 million deaths, including approaching 300,000 deaths in the United States alone. Very unfortunate, as we all know. Now, let's talk a little bit more about GI involvement. The first thing to keep in mind is that the virus actually enters cells through the angiotensin converting receptor number 2, or what we call the ACE2 receptor. And that particular receptor is present in almost all of our organs in the body. It's overexpressed in the intestines relative to other organ systems. So it's interesting to understand that the virus can gain entry to our digestive tract through these cells that express these receptors. there's been some really interesting research that has gone on that actually suggested that there is a differential between what you see in the ileum versus the colon, and there is a differential of these receptors in inflamed ileum compared to inflamed colon as well. So there's been a thought that, well, maybe this actually puts people with inflamed bowels at higher risk for getting infected with SARS or developing COVID-19, but that actually hasn't been held up by empiric data. In addition, you might say, well, why aren't we seeing more people with digestive symptoms overall? And that's because where does the virus enter the body? It enters it through the respiratory tract or through the nasal or oral mucosa. Nonetheless, there has been quite a significant amount of work done in this area. And what people have seen is, for example, you can detect the RNA of the coronavirus in the stool for up to a month after somebody's had an incident infection. That's less than what is seen in terms of how long it may persist in the respiratory tract. And it's also been noted, of course, that a significant number of patients may have coexisting GI symptoms. An important takeaway message for you tonight is that when people have digestive symptoms that are attributable to COVID, they almost always have fever and respiratory symptoms as well. So it's important to keep in mind that while a patient who has new digestive symptoms might be someone you suspect has COVID, if they don't have respiratory symptoms or fever, it's less likely to be the case and certainly less likely to be associated with worse outcomes. On the other hand, it has been proposed that people who develop digestive symptoms with those respiratory symptoms are more likely to have poor outcomes from COVID. And that might just be related to the overall viral load that leads to respiratory symptoms, respiratory tract involvement, coughing and swallowing a high viral load that leads to the digestive tract involvement. So just looking at some of the additional studies that have been done, including now meta-analyses and additional updates, between 20 and up to 50% of patients admitted to the hospital with COVID will have some digestive symptoms, and they're listed here, including nausea, vomiting, abdominal pain, and diarrhea. That's variously defined in the literature. And there's also been a variety of other work that's been done that suggests that it can occur, but it doesn't necessarily mean that there's fecal oral transmission. So let me show you a table of some of the interesting studies that have been done to look at that question. And while it is true that you can pick up the RNA in stool, it hasn't been seen that you can culture the virus from fecal material. So it isn't known that this is actually fecally orally transmitted. And people have looked into this quite a bit, and that has not been proven. So you can detect the virus. That doesn't mean it's being transmitted. But as we all know in our world, that has resulted in us using full PPE during our days of endoscopy, which is what I was doing all day today. Now, let's talk about what leads to hospitalization, because I think stratifying patient risk is very important. We all know that patients who are older have a higher risk for hospitalization, although it is notable that when COVID came to the United States, we were seeing younger people get hospitalized, and at least one explanation was thought to be because there's a higher incidence of obesity in the US. But we've also seen now in the second wave of all this that's going on, that there's a younger population who are ending up hospitalized. Now that may be because they were taking less precautions than the older individuals, or maybe this has actually changed in the population in other ways. In addition, it's been described that patients who are of Black or African American race are at higher risk for hospitalization, as well as those of the Latinx population or Hispanic, and they have worse outcomes. It's been discussed and described that this may not be biologic as much as healthcare disparities in access to care, as well as where individuals are getting exposed to the virus. And there's very interesting work that's trying to clarify this further. But it's certainly important to know who's at higher risk for bad outcomes. And then across the bottom of this nice slide just shows you that we've seen that people with comorbidities also have higher risk for hospitalization and death, including hypertension, diabetes, probably true about chronic lung disease, chronic kidney disease, and what's been suggested in some studies is also those who are overweight or obese. So it's just a perfect storm for those individuals with all those problems that go together with the metabolic syndrome, that they're going to be at higher risk for having bad outcomes. Now, you may have also heard that steroids can be used to treat this disease, and that's counter to what we're going to talk about in terms of high dose steroids risk of bad outcomes in the IBD population. This nicely done randomized study in the UK called the Recovery Trial used dexamethasone in patients who were in the ICU who needed oxygen or mechanical ventilation. It was a specific population, but dexamethasone in that group of people actually did reduce mortality and reduce the need for ongoing mechanical ventilation. So there is a role for dexamethasone, but remember what I taught you, it's at that hyperinflammatory phase later on. It's not the steroid that someone's on at the beginning when they get infected, which is where we worry about that. Now, what you might have been waiting for, and I know Miguel and I were chatting about earlier, is what's going on with vaccines. So there are a number of vaccines in development. You've been hearing it all in the news most recently. You may not realize that there are so many that are in early phase development, as well as 13 that are in phase 3, and 7 that have had some early approvals around the world, but of course not here in the US yet. Now, looking at the vaccines that are in the latest stages of development in the next table, I want you to see that this table includes Pfizer and Moderna, the 2 messenger RNA-based vaccines, but there's also a non-replicating viral vector vaccine from Johnson & Johnson, the recombinant vaccine from the Beijing Institute, as well as an inactivated SARS-CoV-2 vaccine, where they actually use components of the actual virus from 2 different companies. And then the AstraZeneca Oxford vaccine you may have heard of as well, which uses an adenovirus to deliver the actual antigen. So how do the messenger RNA vaccines work? Well, the bottom line is that it's a messenger RNA that codes for DNA that makes a protein that is identical to the spike protein on the coronavirus. That's the part of the coronavirus that stimulates antibody formation. And the general principle here is that by stimulating an immune response to the spike proteins, the body's immune system can then go after the virus and target it and prevent further replication or invasion. The important thing to know, and you may not have heard this yet, is that the messenger RNA technology, which is relatively new, has actually been in development and targeting the spike protein of coronaviruses since those earlier SARS and MERS infections and epidemics. This has been in development for 10 years. It's just that the obvious pandemic led to renewed effort and more rapid development of these vaccines and getting them into trials. As you've already heard, the Pfizer vaccine has a 95% effectiveness at preventing COVID-19. Their package that they submitted to the FDA was made public today. I don't know if any of you saw. I tweeted out a little bit about it, and it's been all over the news, demonstrating incredible effectiveness. It's a 2-dose vaccine, and the FDA is actually reviewing it in a couple days. The Moderna vaccine, in contrast, has a similar efficacy, is also a 2-dose plan. The first dose exposes you to the antigen. The second one triggers your memory B cells, and that's going to be reviewed by the FDA in the following week, a week from the Pfizer one. Now, the Advisory Committee on Immunization Practices from the CDC has been consistently and regularly updating their plans. They voted that the first group in the United States to be getting the vaccine should be the physicians and those of long-term care facilities, nursing homes. And then they also have this stratification scheme where they list different groups that might get vaccinated. And you can see on this slide that the high-risk population would include our IBD patients under the category of use of other immune weakening medicines. Of course, that's good for our patients to be able to get the vaccine. It's a little misnomer in the sense that we don't think our IBD patients overall are at increased risk, and most of their meds, thankfully, are not putting them at higher risk for COVID, but nonetheless, that's where they are. And there's 110 million Americans who fall into that high risk category. So there's going to be some other groups that will get vaccinated with that second wave of vaccinations. So hopefully I've given you a good update. I've talked to you a little bit about what we've learned about this virus. I never thought I was going to be an infectious disease expert, but in the last year, I think we've all had to learn a tremendous amount. And we've certainly learned that there are some populations that are clearly at higher risk for COVID-19 and having those worse outcomes. And we've started to learn a little bit more about how we can target our patients properly. In the meantime, we certainly know that the best prevention has been masking, physical distancing, and vigorous hand hygiene. And that's not going to go away for a while. We've got some work to do. So with all of that, let's move on, and I'll let Miguel take over, and then we'll have some time for Q&A later.
Great. Actually, David, before I leave you right now, there are so many questions coming in. We decided to take a couple now, especially as they relate to the vaccine and some of what you spoke about. So maybe we can do a few brief questions.
Sure.
One of the questions that came in is that there currently is no long-term safety data on the mRNA, the specific mRNA vaccines in patients with autoimmune or immune-mediated disorders. So I guess the question is, what would you advise your colleagues and patients, and should they wait for more or less the traditional vaccine or go ahead with the mRNA vaccine now?
Right. And so let me start by saying, correct, we don't have the data yet. But let me tell you that we certainly know about immunogenicity to vaccines in the IBD population on therapies from other vaccines. And I have spoken with immunologists, several, as well as someone who works at the National Institute for Allergy and Immune Diseases. And I just want to share
by the name of Anthony Fauci.
No, I didn't bother him with this particular question yet, but he's on speed dial, I promise. No, but in all seriousness, the general conversation and perception has been that the messenger RNA vaccine is expected to be as safe or safer than many of the other vaccines that we have explored in humans in general, and certainly in people who are taking immune therapies. The anti-cytokine therapies like our anti-TNFs, anti-IL-12/23, the JAK inhibitors, those therapies are thought not to have any impact on whether you're going to develop immunogenicity to the vaccine with a messenger RNA mechanism. Thiopurines might, because of their impact on lymphocytes. And there was one immunologist I spoke with who suggested that vedolizumab, by virtue of its impact on the alpha-4 beta-7 lymphocytes, might actually result in a less robust immunogenic response. In terms of safety, there are no data from the work that led up to all of this, as well as from these current trials, to suggest that this is triggering some immune response or that it's going to result in people developing new immune diseases. And there's no reason to suspect that our inflammatory bowel disease population is going to suffer from relapses or other problems related to this. So the current recommendation has been, of course, we're paying attention. Of course, we want to see more information, but we're not going to withhold this particular vaccine mechanism from our patients.
Great. And maybe just two other very quick questions before we get to Flo and our first polling question. And by the way, keep your tweets coming out there. We're getting your questions. They're excellent. One is low-dose dexamethasone, and maybe I'll answer this question. There's been a lot of confusion, and I think you did a good job of explaining that high-dose steroids, when you get a viral infection like COVID, may have to do with viral replication and worsening of the actual infection. That's different, as you said, in a patient who's admitted to the hospital sick with COVID and has this cytokine or this inflammatory storm by which we are giving steroids to dampen that inflammatory response. So those are what we think are the two differences between steroids at the time of infection, which we don't want to do, versus this inflammatory reaction.
Right. And remember also who's on high-dose steroids in our population.
Yeah.
They're the sick IBD patients who may have other problems or just have active inflammatory problems from their disease already. So it may also be the types of patients who are on steroids like that who do worse for different reasons.
And then the final question for now, because there were a number of these that popped up, since at least the foreseeable vaccines seem to be 2 doses, people are worried about those that just get one injection, one dose, one vaccine, and don't come back for their second.
Right.
What are your thoughts on immunity, and what do you think about that?
Yeah, so I worry a little bit about that, although in general, the doses seem to be tolerated well, but the immunogenic reaction people have can make you feel unwell for a couple of days, as anyone who's had the Shingrix vaccine may know. That's a highly immunogenic vaccine. And when it stimulates that response in your body, you feel it. So one of the worries is that people will get the first injection and they won't feel great, and then they don't want to get the second one, or they'll think that one is enough. And one of the things I pointed out when I shared the survival curve today of the Pfizer vaccine was that actually your immunity didn't really even kick in until later when you were getting that second dose. And we just have to educate people that the way the immune system works, if you want it to be a durable immunity, or even any that's going to be protective, you've got to get that booster shot. If you don't get the booster, it's unlikely that you're going to have anything worthwhile. So we're going to have to work really hard to, number one, educate people. Number two, track them down to make sure they understand and that they're going to follow up. And number three, make sure we have the vaccine for them so they come back in day 28 and it's waiting for them. So there's a lot of logistics and important information that has to be communicated. And unfortunately, I haven't been convinced yet that there's been any national communication strategy that has been effective. I mean, imagine how much more could be done to educate the populace with the data and to teach people about all this rather than having us try to figure it out as we go along on our end. So I think there's a lot more that needs to be done to address that, and I'm glad someone brought that up.
And obviously that discussion we could have all night about more being done, but let's move on. And before I get to Florian, I actually just want to go through the learning objective and then a case. So thanks, Dave, by the way, that was excellent. Now let's focus on our second learning objective, which is to apply optimal strategies to the management of patients with IBD during the COVID-19 pandemic. And it's excellent timing because you've been starting to hear about this. So let's meet Jackie. This is a case study, a 24-year-old patient who was diagnosed with pan ulcerative colitis 2 years ago. She had been on infliximab since diagnosis and currently is in remission. However, she now presents to you with symptoms that would be typified as a flare. She has pain, bloody diarrhea up to 6 times a day, and you check an infliximab trough level and you see that it's 2.3, but her antibodies are 0. She has no antibodies, and her physical exam is essentially benign aside from left lower quadrant tenderness. You check infection, C. diff, and you also check the COVID-19, which is negative. So we've come to our first polling question. So how would you proceed with Jackie? Would you increase her infliximab dose? Would you switch to another anti-TNF? Would you switch to vedolizumab? Would you switch to ustekinumab? Or I don't know, tell me the answer. Call on our good friend, Dr. Reeder, who's going to educate you in a minute. So take a minute to answer that. We have a lot of people on tonight, so obviously this is a hot topic. All right, so now let's switch gears. Flo, we started talking about IBD and risks, so why don't you go ahead and tell us about the risks of COVID-19 in our IBD patients. So take it away, Flo.
Thank you, Miguel and David. This was a fantastic introduction to, I think, the second topic that is relevant for clinicians. And what I'm going to do in the next 15 minutes is to answer 4 questions for you. The first one is, are patients with IBD at increased risk of COVID-19? And how does COVID-19 affect patients with IBD and their presentation and their care? If you have IBD and COVID-19, do you have any worse outcome? And how can you predict worse outcome in these patients? And then at the end, we're going to talk about how do you manage inflammatory bowel disease in the setting of COVID-19 in patients like Jackie, what Miguel just introduced. And I'm sure you still remember in your own practice when the pandemic hit the United States and the phone didn't stop ringing with your patients calling you to find out, am I at increased risk to contract SARS-CoV-2 or COVID-19 because I have IBD or because I am on immunosuppressive medications. And what turns out, at least from all the data we have to date, is it seems like there is no increased risk of being infected with SARS-CoV-2, and there also does not seem to be an increased risk of COVID-19 among patients with IBD. Interestingly, there are even studies, in this particular example coming from Spain, with the early data coming from high prevalence areas of COVID-19 early in the pandemic. In this particular study, patients with IBD had in fact a significantly lower standardized risk of COVID-19 compared to the general population. Are there any factors within the IBD group that may make you a higher risk for infection with SARS-CoV-2 or for the development of COVID-19? And there is some association data that was just published in Gastroenterology suggesting that if you have moderate to severe IBD disease activity, and as suggested by Dr. Rubin earlier, there is an upregulation of the receptor that takes in SARS-CoV-2 in intestinal epithelial cells and other body compartments. So moderate to severe disease activity, as well as steroid use, were associated with a higher rate of infection with COVID-19. So are our patients with IBD that have COVID-19, do they present any different than IBD patients without COVID-19? And interestingly, COVID-19 can present as a flare in patients with IBD because the symptoms of intestinal COVID-19 can mimic IBD. IBD patients that have COVID-19 have higher rates of new onset diarrhea, abdominal pain, endoscopically active disease. And they can also have elevated biomarkers such as C-reactive protein or fecal calprotectin compared to IBD patients that do not have COVID-19. But I want to emphasize Dr. Rubin's point that most patients that have GI symptoms also have symptoms outside of the GI tract, predominantly fever or respiratory, upper respiratory symptoms. What is important here is to perform a careful clinical evaluation for that reason. You may need to do an endoscopy to distinguish between IBD exacerbation and COVID-19 symptoms. But if in doubt, we recommend to obtain a SARS-CoV-2 testing, which is fortunately now widely available. Fecal calprotectin, which many of us use as a surrogate for intestinal disease activity, can be elevated in patients with COVID-19 and diarrhea, and it can be elevated if they currently have diarrhea, but also if diarrhea is already resolved, if you compare those to patients without diarrhea. So there is an overlap between intestinal COVID-19 and inflammatory bowel disease in our inflammatory bowel disease flare in our IBD patients. And ultimately, aside clinical judgment, SARS-CoV-2 testing may be necessary to distinguish the two. Most of what we learned about inflammatory bowel disease and COVID-19 comes from the Secure IBD registry. And this is publicly available information that you see here. You can find that under covidibd.org. And this is a very important global initiative that has been led by the Mount Sinai in New York, University of Calgary, and the University of North Carolina. What this registry does is it collects any patient, if you can go back one slide, it collects any patient worldwide that has inflammatory bowel disease and COVID-19, and anyone can enter this. It's very simple, and I want to encourage every one of you, even when you have a small practice, if you have a case like this, you should enter it. You should continue to enter it, even with the emergence of vaccinations, because there's a lot of information we still do not know about the interaction of these two diseases, particularly long-term effects. Next slide. By now, more than 3,500 patients with IBD have been entered into the Secure IBD registry by the beginning of December of this year. And important information derived from this registry particularly informed us about which medications are considered safe during COVID-19 and which medications may be associated with more severe disease courses. And what came up in our IBD patients, just like in the general population, older age or certain comorbidities are linked to more severe outcomes of COVID-19. The corticosteroid signal is quite prominent, particularly in higher doses of greater than 20 milligrams prednisone equivalent per day. But then there were also signals about thiopurine mono in combination with anti-TNF therapy, with conferring worse outcomes for infected patients. Interestingly, aminosalicylates in the form of mesalamine or sulfasalazine also ended up in the severe COVID-19 association category. However, here it is unclear if there is a pathogenetic relevance to this, or this is just a bystander or surrogate for active disease in this population. Initially, it was believed it is just a surrogate for active disease. However, the same signal keeps on popping up in multiple different studies. I still believe it is likely linked to active disease rather than the medication itself, but I think this is an association that we should continue to watch. For the benefit of our patients, factors not associated with severe COVID-19 includes the commonly used biologics, anti-TNF monotherapy, and then ustekinumab, as well as vedolizumab, all of which were answers for Jackie's, potential answers for how to treat Jackie in our case study. Next slide. So the other question that came up is IBD itself a risk factor? And is this risk, in fact, shared with other immune-mediated diseases? And in this prospective case series of 86 patients, patients with immune-mediated diseases were pooled, such as with inflammatory bowel disease, rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and psoriasis, with suspected or confirmed COVID-19. 72% of them were on biologics or JAK inhibitors. A higher percentage of the patients that were hospitalized received this targeted therapy compared to outpatient. But what came out on multivariate analysis was that hospitalization or need for hospitalization, again, was associated with oral steroids, so steroids as a risk factor for more severe outcomes, but also methotrexate, the other most commonly used immunomodulator, aside thiopurine in inflammatory bowel disease, as well as hydroxychloroquine. Hospitalization rates in general were consistent with the general population, again highlighting that IBD, as well as other immune-mediated diseases, are not a risk factor for contracting SARS-CoV-2 or COVID-19 as far as we know to date. One other point I want to make is that active disease does not only seem to be a potential increased risk for contracting COVID-19, but also if you have IBD and active disease, you may have worse outcomes of COVID-19. And this is an observational cohort study from Italy, 79 patients, where they followed patients with IBD and COVID-19 in the hospital towards ICU admission or related death. And again, age and comorbidities are the strongest predictor of worse outcome, but active IBD on its own was a predictor of more severe outcomes, including death. Interestingly, looking at the two different diseases, ulcerative colitis and Crohn's disease, ulcerative colitis in general seems to be associated with worse COVID outcomes. So how do we put this all together to manage our IBD patients when they have a relapse during the COVID-19 pandemic? When they come in to see you, you first want to find out if there are symptoms or findings suggestive of COVID-19. And we talked about a large overlap between those and symptoms of an IBD flare, and looking for symptoms outside of the gut, such as upper respiratory infections or manifestations or fever. If the symptoms are suggestive, you should get a SARS-CoV-2 test. And if this test is positive, you want to reduce the dose of corticosteroids, because this is a major risk factor for potentially for infection as well as severe outcomes. And by taper, we mean to go below 20 milligram of prednisone equivalent, or taper even lower if possible. You can switch to local delivery corticosteroids, such as budesonide MMX. What you can continue based on current recommendations is mesalamines, local corticosteroids, as well as local rectal therapies. You want to hold thiopurins, methotrexate, as well as tofacitinib. And if the patient has symptoms of COVID-19, you want to hold biologics until COVID-19 resolves, and we're going to talk about that in a second. If the patient has severe COVID-19, you want to focus everything obviously on life support and treatment of COVID-19. You hold all anti-inflammatory or immunosuppressive therapies. If the patient tests negative for SARS-CoV-2, when you have a suspicion for it, and you want to go to the green box on the slide, you consider that this is an IBD relapse that is unrelated to COVID-19. You want to confirm inflammation. You want to, during a pandemic, particularly in highly endemic areas, that you want to reduce the use of endoscopy because of potential spread of the virus through the stool, even when in the upper respiratory tract with PCR test, the patient is negative. This is an example, for instance, in our case, Jackie, you may just do a fecal calprotectin to confirm that our patient has in fact a disease flare. You then treat the patient in principle, just like you treat an IBD patient outside of this pandemic. You confirm drug concentrations of the drugs the patient is on, such as thiopurins or biologics. You ensure that the patient is adherent to her or his therapy. If it's only mild IBD, you can dial back potentially on therapies, can consider topical therapies only in the rectum, oral budesonide, so local delivery steroids, or just symptomatic therapy. However, if the patient has moderate to severe IBD, you want to treat the patient as if you would treat the patient normally, because active disease is a risk factor to contract SARS-CoV-2 or COVID-19. The only modification is to consider avoiding immunomodulators, such as thiopurins, methotrexate, or tofacitinib. I'm going to repeat the management because I think it's important in simpler terms. So if you have IBD, you have no symptoms, and you have not been tested, you just continue your therapies and you treat your IBD just like you would treat your IBD patients normally to keep your patients in remission. If you have no symptoms and a positive test for SARS-CoV-2, you hold any therapies for about 14 days. If you have a positive test and symptoms, you hold IBD therapies. When do you restart therapies in a patient that contracts COVID-19? You want to wait at least 3 days without symptoms suggestive of COVID-19. So if the patient recovers, no fever for 3 days, or if the patient tests negative with PCR on 2 separate occasions, at least 24 hours apart, or if the patient enters the convalescent phase of immunity. Then an interesting paradox emerged because all our IBD patients were worried that due to the immunosuppressive therapies, they may have a higher risk for more severe outcomes. But what happened was that in fact, our IBD therapies are now used in clinical trials to improve outcomes of patients with COVID-19. And the reason behind it is the cytokine storm that Dr. Rubin talked about. If you can prevent that from happening, and if you can prevent damage from happening, you may have a higher chance for your patients to do well. Examples are on this slide. Infliximab has been used in 2 patients for both IBD and COVID-19 when they were co-infected. And the TNFs and JAK inhibitors are evaluated as potential COVID therapies in randomized controlled clinical trials, so tofacitinib, infliximab, and adalimumab. And interleukin-23 blockade may also potentially suppress the cytokine storm syndrome and has been used successfully in a patient with psoriatic arthritis and COVID-19. So in summary, the 4 questions I started with. Are patients with IBD at increased risk of COVID-19? They are not at increased risk of COVID-19. How does COVID-19 affect patients with IBD and their care? There is a significant overlap between symptoms that COVID-19 can cause in your GI tract in IBD patients and an IBD flare. So you want to clinically or by testing distinguish the two. Do patients with IBD have worse outcomes with COVID-19? And the general risk factors here are comorbidities, age, active disease, and corticosteroid use. And what we want to tell our patients that are in remission and are on biologics, they should be continued during the pandemic, except if you're positive for SARS-CoV-2. If you have the choice, you want to avoid immunomodulators such as thiopurines, methotrexate, and tofacitinib. And with this, I hand it back to Miguel to solve the case with Jackie.
Great. Well, thanks, Flo. Why don't we do this? We'll do the case follow-up polling questions, but Flo, there's so many questions coming in for you that I'd like to take a few of those now before we get to the final learning objective. So maybe we can go back to the case of Jackie. Now, this is a little bit different. So look at her drug level when you answer this part. So again, 24-year-old, ulcerative colitis, had been on infliximab, doing well in remission, comes to you now flaring with pain, bloody diarrhea. The previous case, her infliximab level was low without antibodies. Now her infliximab trough level is 15.4, and her antibody to infliximab is 0. Colonoscopy shows moderate to severely active pan-ulcerative colitis. Again, C. diff is negative and SARS-CoV-2 is negative. So let's go to this polling question. How would you proceed with Jackie at this point? Increase her infliximab dose, switch to another anti-TNF, switch to vedolizumab, switch to ustekinumab? I don't know, and I'll give you Flo's direct cell phone number. So maybe a little bit different polling question than the first based on her levels of infliximab. And Flo, as people take a minute to answer that, and we'll go through the actual polling results at the end of the whole program. But there were a number of questions related to switching somebody on an anti-TNF or on an anti-TNF to vedo or ustekinumab. Mm-hmm. So what are you doing, or what are you telling your patients who may be exposed to COVID or just simply walking around in the world that we're in today? Are you intentionally switching to vedo or ustekinumab, or are you leaving them on their anti-TNF or their therapy that they're currently on? I know you mentioned that, but how are you practically approaching that?
Yeah, so this is, I think, an important question that came up frequently. And in fact, just a few hours ago, a patient called me with exactly this question. So the key pillars that I communicate with my patients about is use all precautionary measures that you use for non-IBD patients, which is hand washing, social distancing, wear a mask, avoiding large crowds, and all the common health recommendations. The key thing is to keep the patient in remission, because if the patient gets active disease for whatever reason, the risk of infection, worse outcome goes up. So if the patient is on whatever biologic, infliximab, vedolizumab, or ustekinumab, and is doing well, I do not recommend to switch. Having said that, if the patient is on combination therapy and is in a high endemic area, and for instance has infliximab and thiopurines or infliximab and methotrexate, you can have a discussion about discontinuing the immunomodulator if the patient has been on combination therapy for at least a year. But when in doubt, I continue the patient on the current therapy in remission. There is a general belief that vedolizumab may be a safer choice during this pandemic. The data is yet lacking. Theoretically, it makes sense from a mechanism perspective. The same is true for ustekinumab over anti-TNF, because anti-TNF are considered to have a higher risk for viral reactivation or susceptibility to viral infections. But it has not yet panned out in all the data we have, and I would continue the patient if the patient is in remission.
Great. David, do you have anything to add? And then Flo, I'm going to ask you a question about TOFA.
Well, the trough level is a little low, and if this patient had attenuation when I took a history, in other words, that she felt better, somewhat better with her infusion, but then didn't get back into remission, I would try to optimize the first therapy. So there's nothing wrong with trying a different mechanism, and certainly I don't disagree that you have safe options to give the patient here, but I might first give her an extra dose of infliximab and see if I can't push her over the edge, because she was responding to it. She's got a low trough level without antibodies.
If we switch to the first patient, I totally agree. That I was answering the question from the Twitter box
Second
that
patient.
Miguel was
Oh,
asking.
the Twitter question, yeah.
Yeah.
And
So I
the
totally
first
agree.
patient, that's the way I
first.
would have thought about it. Yeah.
Okay. And then, Flo, there was a question about TOPA, and just for the polling question, we made it confusing. The first poll question was a patient with inadequate drug levels that were low, no antibody to infliximab. The second patient actually had what I think all of us would say was a good trough level at over 15 and no antibody. So
yeah,
we'll go through the actual polling questions in just a second, but Flo, if I could ask you one question on the tofacitinib. So you mentioned kind of like steroids. You said on one hand, tofa should be avoided during this time of a pandemic, yet it's being studied to look at a pandemic. So that's confusing people.
Yeah, it's not only confusing to people, it is confusing to the field. So I think there are two reasons. One is early in the pandemic, and this is still the case, data is missing on outcomes of certain medications. And then expert groups provide their best expertise in a consensus format, which leads to recommendations, and you make a lot of judgment calls. And I think it's justified early on to make a judgment call that drugs like tofacitinib have a higher susceptibility for viral infections, as is well described for instance, herpes zoster infection. The second point is the timing of the administration of, for instance, a drug like tofacitinib, because if a patient is on it, or if a patient has asymptomatic infection, you may push the patient towards a worse disease outcome or give the patient a higher risk to get infected. However, when there is a cytokine storm situation and the patient is in the ICU with ARDS, respiratory symptoms, high fever, you want to use medications that can suppress this extreme immune activation, and JAK inhibitors could be very effective in that. Without wanting to get too much into detail, there is a different class of JAK inhibitors that's not been tested in IBD. Baricitinib is the name. It's a JAK2 TYK2 inhibitor that may actually suppress the uptake of the virus into cells and hence potentially prevent infection or prevent more severe disease. But this is a moving target, and data is evolving. But I think it's timing and timing throughout the disease and listening to evolving data mainly.
Great. And so everybody out there, please keep your questions coming. They're excellent. Also, I realized that I was a little slow, and those in the Twitter land are actually seeing the poll results. Maybe I can ask if we can show those poll results one more time, and if not, we can keep moving. But I think we discussed this a little bit already. So, and while we actually do that, but I think we're probably gonna, the results are up. So, David, to your first point, the patient that had the low level infliximab, it sounds like you would be interested in increasing the infliximab. You have no problem with that. It worked well. And then, Flo, I think your second case, the patient who has adequate drug level of infliximab, then the toss-up becomes veto and ustekinumab. And you mentioned, and it seems like there's kind of a split there, a little bit of a split, that the patients actually, people out there trying to decide between veto and ustekinumab. Maybe there's some data that veto might be a little bit safer, but we have no data in COVID. And you'll get to, in a minute, the safety slide I'm going to show where I think veto and ustekinumab are probably equal. I don't know, David, do you have
Miguel, there's a study presented at DDW this year that's now in full published status, I think, that from the Netherlands, where they looked at after patients had lost response to anti-TNF, is ustekinumab or vedolizumab a preferred option? Now, without knowing all the details about those individual patients, ustekinumab was more successful in that setting. Now, what we're really missing in all these different analyses is any understanding of the immunology. What I can say is exactly what you emphasized, which is that we want to make sure we're moving to a safe therapy in the setting of the pandemic, and that we're going to get the patient well as quickly as possible and minimize steroids, which is what we've always said, pre-pandemic, post-pandemic. I'll also mention to everyone that there's a very nice paper by our colleagues in France and Belgium, where they described the importance of matching disease activity with the therapeutic drug concentrations. In other words, make sure that you're assessing the disease activity when you're interpreting the serum concentrations of the drugs so that you compare the two together. And I because of that paper and other commentary, I've started to move away from the term therapeutic drug concentrations in general, and thinking about thresholds, but more just trying to understand, is the drug present and how active is the disease, and have I optimized or not, and then move on. So I think I hope I'm not confusing people, but those are the things that lend themselves to my decision making.
Great. Well, why don't we move to the third and final learning objective, and then we'll have more time at the end for your questions. So the third learning objective is to identify tips and tools for providers and patients in the community setting during this time of COVID-19. So before we do that, let's actually get to our next patient, Anastasia. Anastasia is a 37-year-old female who was just diagnosed with moderately active Crohn's, and her current symptoms are 10 to 12 bowel movements a day. She has 1 to 2 nocturnal symptoms, urgency, frequency, frequent blood, and abdominal cramps. Colonoscopy shows scattered ulcerations throughout the colon with rectal sparing, consistent with moderately active Crohn's colitis. C. diff and SARS-CoV-2 are negative. She was prescribed an intravenous biologic, so today that would be vedolizumab or infliximab primarily, or a single dose of ustekinumab, but is concerned about going to the infusion center out of fear of infecting her elderly mother who lives with her. So let's look at this polling question and see how you would respond to this. How would you approach your conversation with Anastasia regarding to her infused biologic? A, address her concerns and explain relative risks and benefits of getting her medicine. B, recommend switching to an option that does not require trips to an infusion center. C, recommend continuing her medicine, but only if she can completely isolate herself from her mother. Or D, again, I don't know, tell me the answer. So why don't we go ahead and vote, and then we will come back to this at the end. And I'd be curious, actually, Flo, I know you and I practice at the same place, and Dave, when we come to this, see how we're discussing this with our patients in terms of infusions. I have a feeling the three of us are probably doing something very similar. So we're going to move on to a bit of telemedicine, which I think all of us now are using widely in whatever practice we're in. And I think telemedicine has really gained prominence within this pandemic. And this is a study survey that I was involved with IBD, where we looked at the use of video medicine, telemedicine, which would be the orange or the pink, compared to telephone visits in blue, and face-to-face during the pandemic. And you can see it varies by the part of the world you're in, but at least in the United States, we saw a definite uptick in telemedicine. So how about the IBD survey in the pre-COVID? Well, we saw mostly face-to-face prior to COVID, and then not surprising during the pandemic, mostly telephone or video. I will mention, I should say, with telephone visits, the practical reality is the payment for these is going to go away, we think, at some point. So from a practical reality, probably telemedicine is going to be our best bet and what we're going to do in our offices. And maybe at the end, I'll engage Dave and Flo a little around telemedicine. So let's consider telehealth before and after the pandemic. So prior to COVID-19. I'm not going to read off the entire results, but the survey that we found were that 41% of GI physicians plan to use telemedicine actually more often prior to COVID-19. When we consider the overall population in practice, we are seeing different platforms for telemedicine. So there's Zoom, there's Doximity, there's FaceTime, there's Skype for Business. And again, these are all modalities that are being used more and more widely. And then when we consider advantages and disadvantages to telemedicine, I think all of you have seen this in your own practices, but certainly advantages are that in some senses, patients often prefer these actual virtual visits. They don't have to travel or wait. It's more convenient to access primarily from home, and there's fewer canceled visits. Providers can actually improve efficiency, increase volume. We can now bill at the time for phone calls, but certainly now for virtual medicine. And this limits the person-to-person contact. The disadvantages, well, there are several. Privacy issues, although I think we've overcome most of those. Sometimes there's a sense of lack of bond, although I should make an interesting caveat. I was told by a patient yesterday. In the office, I wear a mask and a shield. On the telemedicine, I'm sitting here like I'm talking to all of you. And actually, it was interesting. The person felt on telemedicine, there may be actually more personal contact. So interesting. But the disadvantage of telemedicine is the administrative staff, especially if we want them to load visits. And the most obvious is the inability to perform a physical exam, although there are ways to actually now do that. If a patient doesn't have access to technology and access in general, that can be a big barrier. David talked about disparities, and we are seeing, unfortunately, some disparities in terms of access to telemedicine. In terms of recruitment for research protocol, collecting biosamples, if we wanted to give something like a vaccine, obviously telemedicine, we can't do that. And then we also have to figure out how we are using our trainees and others involved in this. So let's move to consider the impact of telemedicine on the management during the COVID-19. And when we look at this retrospective analysis from New York City that was presented at ACG just recently, on the left-hand side is the impact of COVID-19 on the diagnosis and management of GI diseases. And you can see that missed labs, missed imaging are probably the two primary. Less so the inability to refill medicines or to get medication, so more around labs. What about on the right-hand side, the acuity and type of GI procedures during telemedicine? And you can see the different types based on coding, but if you focus on probably the most common, the orange is colonoscopy and the gray would be EGD. You can see that there's actually a discrepancy between the urgent and the routine, and certainly during the time of the pandemic or when we were really shutting down, routine procedures went away and we really were only focusing on the urgent. So what are some of the best practices when we consider using telemedicine? Again, I'm not going to read this entire slide except to say we need to consider the setup. We need to look at the type of the platform that we're using. We need to consider how compliant this is for local governments and also how easy this is to implement for our patients and providers. We should look at pre-visit preparation, so workflows, instructions to patients, making sure this is very clear. Also that the clinic staff initially when we started this had some dress rehearsals that we would do to get used to this. Utilizing electronic tools to collect information and data. We do have our staff pre-chart, which I find is actually very helpful. And we obviously want to find a place that's quiet and certainly is private. And we also need to determine if telemedicine is performed by the patient in the clinic or if we can actually do this from home. And maybe there's some tips and tricks. And then finally, during the visit, we need to consider rooming the patient, getting verbal consent to do the video visit. That's actually a requirement And from a CMMS and payment standpoint, that's a requirement. So we all now have smart phrases that we use. There's a limited ability to get a physical, but we can. And then obviously once we complete the visit, we want to communicate to the patient. So we also have to address technology challenges, and this certainly comes up quite a bit. And obviously we need to be ready to convert to a FaceTime or telemedicine, or sorry, a telephone visit. And then after the visit, we'd like to provide some after-visit summary and documentation for the patient. And then for the patient convenience, drive through pharmacies, and then instruct our staff how we are going to follow up with that patient. And then finally, during the visit, we often will use a similar note template, and probably we could talk to you about some of the dot phrases that we use. But let's now switch to the infusible biologics and the adherence of infusible biologics. And this was kind of the question with Anastasia in terms of the infusion that she was going to receive. This was interesting, looking at a decrease in adherence to infusible biologics. And this was a US nationwide VA cohort in which up to 25% of patients had intervals beyond their normal interval, out to over 10 weeks. And that non-adherence to infusible biologics increased by 70%. And you can see the gray line is in 2019 pre-COVID, and kind of the blue-green line is actually 2020 during COVID. And you can see, especially when COVID struck, the infusions went down. But we talked a lot about safety, and you've seen the safety pyramid before. This is something that Ben Click and I published last year in our looking at how we consider safety overall. And the safety pyramid, and you heard us talk about the biologics. Now, I should mention the safety pyramid is our opinion based on data, and this is not specific to COVID. This is just safety of overall medications. And we really consider bevacizumab and ustekinumab at kind of the top of the safety pyramid. And in my opinion, I would consider either of these as very safe during the time of COVID. But then also we should consider other medicines that include combination with anti-TNF. And if we think that that's the best treatment, we should use it. But certainly from a safety standpoint, and Flo already mentioned thiopurines in the time of COVID, is something we need to take into consideration. And at the very bottom, you see steroids, which we've talked about not just with COVID, but in general with safety. And then inadequate treatment, we should really consider as a safety event. So we shouldn't undertreat our patients, even during the time of COVID. And I completely agree with David and Flo. We don't stop our biologics in patients in remission just because of the world of COVID. So let's go back to the case with Anastasia. And I'm going to give you a summary, and then let's get back to the case with Anastasia. And the summary really is talking about the infusible biologics and adherence. I actually feel that infusion centers have done a tremendously good job during this time of COVID in terms of safety, keeping our patients safe, keeping connected, following social distancing and masks. And then obviously telemedicine, telehealth, virtual visits. I think these are here to stay, and there is definitely some benefit. So now let's get to our Anastasia, and let's see what the polling shows. And David and Flo, in a minute, I'm going to also gauge you around this. So Anastasia, again, 37-year-old Crohn's, active symptoms, colonoscopy shows disease, active Crohn's, colitis. And now the question is, she's starting on an IV biologic, but she's worried because she doesn't want to come to an infusion center out of the fear of infecting her elderly mother. So let's go to some of the answers, or the question again. So with everything you heard, how would you approach this conversation with Anastasia, addressing her concerns? Would you address her concerns and explain relative risks and benefits? Would you recommend B, switching to an option that is not requiring an infusion center? C, recommend continuing her medication, but only if she can completely isolate from her mother? Or D, I don't know, tell me the answer. So let's see what people respond to that. And I'll just say while we get those poll results up, and I'm going to look this time on Twitter too to see if I can see the results pop up. But let's start to have maybe a discussion about this now. David, what are you telling your patients about infusions during this time of COVID?
This was a question that came up right away in the very beginning, and the message was for patients to have a communication with the infusion center. What is their policy and how are they taking precautions to protect the patient? Are the chairs physically distant from one another? Are you assigned a single nurse who's only working with you, who changes her or his gloves in between caring for you? Are they using the most up-to-date approach to doing the infusions in a short amount of time? Do they check your temperature when you arrive? And what we did locally in Chicago is communicate not only with the University of Chicago's infusion center, but with the third-party infusion centers that we work with, and made sure they all had the same approach and worked with them. We then subsequently actually looked back to see if our patients were adhering to their scheduled infusions. And in our center, we found no drop-off, and that was because we were actively communicating with them the importance of staying well and not taking these chances. There are other places in the country, like New York City, where my colleagues tell me that it just wasn't possible, and they started using more home infusions. But in general, I am more nervous about that, of somebody going from house to house, despite best intentions, potentially causing troubles. So those are the general things that we've done, and that's how I've communicated it.
Correct. So let me actually just, I have them online, and that actually just popped up and then just went down. I guess I'll ask Flo while I try to pull it back up. Is there ever a case you would switch somebody to a sub-Q or an oral medicine, or what do you think about that?
Yes, so I agree with David's assessment completely, and I would do the exact same thing. One big learning in the pandemic, aside many other things, was the communication strategy that became necessary when communicating with our IBD cohorts that all of us have. Needs to be much more active. New tools have been explored, such as MyChart messages, active calling with predefined scripts, for instance, about infusion centers and so on. And interestingly, we learned it very early on from Chinese centers when the pandemic started, how well the IBD patients did. So to come back to the question, I think a lot of the answer, Miguel, that you asked me is about communication. And I do think that the 62-63% that you see here, addressing concerns about risk and benefit, that's what I would try first. There are a few patients that will be so concerned that they rather stop or not take their IV medication if you force them, if you will, to go to an infusion center, and they want to be switched to subcutaneous. And if by all tools that I have available, I'm not able to convince and make the patient feel comfortable, I would recommend switching to an option that keeps her disease in remission rather than the patient not taking any medication.
Great. And so like you said, and now I'm able to look at the poll, pre and post, really about 2/3 remain that they would continue the infusion, just go through the risk and benefits, exactly what you just said, Flo. And really only about 1/3, and maybe a little bit of an uptick after the discussion, would actually go to a subcutaneous injection. And just to make clear, I would clearly continue the infusion. I wouldn't avoid an infusion. And I think it's just a matter of reassuring our patients. And like David said, I think we're taking better precautions now in our centers. Let's actually wrap up the discussion. I'll present a few more slides, and then we're going to get to your questions. So the SMART goals are: stay current on the recommended treatments for the prevention approaches in COVID-19. During the pandemic, again, we should continue our IBD therapies and infusions. We should avoid high-dose steroids, and then weigh the risks and benefits of thiopurine, methotrexate, and tofacitinib. We should expand the use of telehealth during the pandemic, and I think all of us have done that. And we will recommend the SARS-CoV-2 vaccine. So I think all of us are going to recommend that. Yes, we need more information, but clearly this pandemic merits the vaccine of our patients with IBD. So let's go to some questions, and we've received a number of questions already. You can keep sending them via the Q&A widget on your screen. You can email us at questions@cmeoutfitters.com, or you can tweet using the hashtag COVID-NGI. So let's go to some questions, and let me pull them up here. And then, you know, there was an interesting question. Maybe I'll ask David this first, and then Flo will ask you a different question. Ostomies, in terms of, are you doing anything? Should we delay ostomies? Is there any reason we shouldn't be performing ostomies in our patients? We didn't really talk about surgery during this time, but what do you think about that?
Well, we started at the beginning of the pandemic with the RAND panel assessment that you were part of as well, Miguel, looking at the expert opinions about patients with IBD. And one of the questions we asked the group was whether patients with J pouches or ostomies were thought by the group to have any increased risk for SARS infection or COVID-19. And the group was strongly in agreement that they're not at increased risk. So there's no reason to delay an ostomy if someone needs one. The only issues are logistical regarding whether or not there's appropriate time now in the overcrowded hospitals to have OR access for what might be viewed as a semi-elective procedure in some situations. Nothing else about it would make me worried.
Yeah, so the specifics to an ostomy we're not worried about. It may be the ability to have an overnight stay in the hospital with our hospitals being overrun, but I completely agree with that. Flo, you mentioned the risk factors and ulcerative colitis and Crohn's. Are ulcerative colitis and Crohn's risk factors from some of the data you presented with the Secure IBD registry? Are there differences between ulcerative colitis and Crohn's and risk and severity of COVID-19?
Yeah, from all I can gather from the data, the risk is disease activity rather than the diagnosis. So my suspicion, but this is not these big registries have the benefit of being big, but the limitation of having not all clinical data available that you would wish. But my interpretation of the data is that the inflammatory burden that drives the risk, depending on if you have Crohn's disease or ulcerative colitis, and these patients that are hospitalized with ulcerative colitis often tend to be sicker with a high inflammatory burden compared to Crohn's disease patients. And that would be my interpretation of one having a higher risk than the other. But in general, inflammatory bowel disease patients do not have a higher risk compared to the general population to contract the disease.
And I think that's right. And we haven't seen disease-specific risk separating. And as you said, I think that so far it has to do more with the active inflammation and high-dose steroids. David, there are a number of vaccine questions. And I'm going to do kind of quick question, quick answer. Some of these I know require more of an answer. But for the two vaccines, the two series, is the actual strength of the vaccine the same based on the first one and the second one?
I don't know the answer to that.
Yeah.
I think they are. I believe that it's the same. I don't think it's going to be labeled number 1 and number 2. It's essentially the same. But it's the way your immune system responds to the first antigen exposure and then to a booster that triggers your memory B cells.
And that's my understanding. We actually had a meeting here at Cleveland Clinic yesterday about this, and that's what we think, but we're going to wait and see. What about the pharmacist? Are you using pharmacists for vaccination, and then are you monitoring for side effects after the injection? I mean, we haven't done it yet, so this is, what are you planning to do?
We are planning to have our nurses do this, but every patient who gets vaccinated will be in a registry that we're maintaining, and then separately we're doing our own research protocol that we're collaborating with some of our colleagues, including you guys, I hope. So it's not going to be the pharmacist per se, it'll be nurses who are trained.
Right, and then the patient who's recovered from COVID-19, should they still receive the vaccine?
Yeah, that's a good question. And right now the answer is yes. In part because we don't know what the extent of immunity and durability of immunity is from a native infection. And in general, the recommendations for other infections, like if you've had shingles, you're still recommended to get the herpes zoster vaccine. So I think it's going to be the same, that you want to get actual immunity from these vaccines, which will be more profound and durable. But I think it's a good one that needs to be answered further.
Yeah, and I think we're going to recommend that our patients still get vaccinated. Flo, it looks like there are a number of
Miguel, let me add, I'm actually looking at the FDA packet from Pfizer right now.
Yeah.
And scrolled through, and the 2 doses are the identical amount. It's 30 micrograms, 0.3 mLs.
Okay, good. So it is the same.
21 days apart. Yep.
21 days apart, same dose for the first at day 0 and at 21. And it's just, as you said, it's the immune response to the second.
Right. Page 11 of the FDA packet.
Age 11. Perfect. Glad you pulled it up.
Yep.
Hot off the press.
Very.
All right. Flo, can endoscopy distinguish between an IBD flare and symptoms from COVID?
Yeah, so this is obviously also an excellent question. So COVID-19 intestinal infection, from all we know, can present with endoscopic findings of disease. So you can have inflammation, erosions, ulcerations. It is not studied well enough to see if you find signs of chronicity on a biopsy, but if you have IBD already, and on top of IBD, you develop COVID-19, the two can potentially be not distinguishable. So the factor that I use in my clinical practice is if a patient comes in with flare and has symptoms outside of the GI tract, particularly fever and upper respiratory symptoms, I get a SARS-CoV-2 test. If I have any suspicion for SARS-CoV-2, I get a SARS-CoV-2 test. Another example is a patient that has a flare and says, I can't smell and I can't taste anymore. But if none of this is true, and the patient has IBD typical findings on endoscopy, you cannot distinguish the two from one another.
Great. So Flo, a couple more quick questions. We're also getting some nice comments coming in. Excellent program, great speakers. Thank you for your time. Did Dr. Rubin get a quick workout in before the program based on his attire?
Yeah, my workout was doing colonoscopies all day, like all of you know is like, and I didn't make it home in time.
But I see some product placement, David, on your left shoulder.
Yeah, I'm not getting any royalties. Wearing
your bicep, you can just do this a couple.
Okay, enough. Please move on.
All right, we have just a few more minutes. Flo, in terms of the, I just, of course, lost my place. Oh, gender differences. Are there gender differences based on secure IBD registry or anything you're seeing in gender? You mentioned minority differences and differences in terms of ethnicity and race, but any gender differences?
Yeah, there are gender differences that have been reported. Now, I hope I don't mix up the two, but I believe males are at higher risk for more severe courses, but please correct me if I'm wrong. There have been gender differences reported. I believe males were the predisposed genders. Do you remember the same, Miguel? Or
so it's interesting. Initially, it seemed that this was males of a certain age. When you look at the totality of the data now, there's an evening that's occurring. So we aren't seeing quite as much of a difference.
There was males in the beginning then. Yeah. Okay. Yeah.
David, there's many questions about mutations. And I think you kind of mentioned this. Is this something that's going to mutate? Are we going to see different strains each year that are going to require a new vaccine every year?
The latest information that I've read, and I've been looking for this, says that this is not a mutated virus, that this is going to be it. Whether we need to be vaccinated or get boosters later is unknown, but it's not expected that there'll be a variation to this particular virus. Now, How can I say that with any confidence? I'm only quoting experts that I've asked and tried to push on and read about. So for now, the answer is no.
Okay. And then Flo, a practical question to a lot of the alternative medicines or alternative treatments out there that patients are reading about, vitamin D, zinc, famotidine, any data, are you recommending any of that?
Yeah, so there has been particularly early on a flurry about which medications could potentially affect infection with COVID-19 or could influence the disease courses. None of them were controlled, and the best example for the hype was hydroxychloroquine, and that created a lot of confusion. My personal opinion and the totality of the data is I do not recommend to take any of these vitamin supplements, acid suppressive medications, hydroxychloroquine and others, for the sake of preventing COVID-19 or preventing SARS-CoV-2 infection or preventing COVID-19. I do not recommend to take any of these for the sake of this purpose. If a patient is on it for other reasons, obviously, by all means, please do it. You don't need to stop them, but I do not recommend any of those.
Great. And then David, maybe I'll ask you one last question that just popped up in terms of small bowel versus colon, any differences in terms of cytokine store, any differences in general?
Well, there are a couple different papers that have suggested that the expression of the ACE2 receptor is different in the small bowel versus the colon, but it hasn't been correlated to differences in clinical outcomes. So for now, the answer is it doesn't seem to make a difference.
Okay. So let me wrap up just by a few concluding remarks. So to receive your credit, you see it on the screen here. That's the CME credit. Put in your ABIM ID number, your date of birth on the evaluation so we can submit your credit to ABIM. The CME for MIPS improvement activity, please complete the activity post-test and evaluation at the link provided over the next 90 days. Work to incorporate these improvements into your clinical practice. Complete the follow-up CME Outfitters survey in the next 3 months. And then finally, visit the COVID-19 and GI hubs. We put up some useful links here. The CME Outfitters sites, these are all free resources, provides a lot of the information that you heard tonight. And with that, one more comment about the vaccine, and then I'm going to thank both Dave and Flo for their time. Again, both doses are the same, so thank you. Both doses of the Pfizer vaccine are the same. We should probably qualify that. And they're given at day 0 and 21. And we are recommending for all of our IBD patients to get the mRNA vaccine. We certainly think that any small risk is far outweighed by the benefits. So thanks again to Dave and Flo. This has obviously been another great discussion. I've certainly learned a lot from both of you. I think this is an evolving field. IBD is obviously a hot topic during the COVID-19 era. For any out there that missed today's program, it will be archived at cmeoutfitters.com, cmeoutfitters.com, along with useful information on COVID-19 and GI. So with that, thank you everybody for your attendance. We hope to see everybody soon in person. Stay safe and well, and have a good day. Have a good night.
Thanks, Miguel.
Thank you.